Well, we're delighted to have back by popular demand Dr. Ashley Lewis. In spite of what the schedule says, she's today's speaker. And we're delighted since we really liked her last presentation. Today, Dr. Lewis, who is a graduate of Meharry Medical College in Nashville and who has done her training here at Shands and is a fellow in geriatric psychiatry, is back to talk to us today about schizophrenia, the differential for psychosis, and this really applies to people in the older age range. So welcome, Dr. Lewis.
Right. Thank you so much. I will begin sharing my slides. Thank you so much for having me back. So as already mentioned, today we're going to be talking about schizophrenia spectrum and other psychotic disorders in the elderly. And I am Ashley Lewis. So the objectives for today, we're going to define some terms. We're going to discuss psychotic symptoms. We're also going to once again delve into the DSM-5 criteria for schizophrenia and delusional disorder. Talk about some epidemiology as well as treatments for psychosis. Delusions, hallucinations, and psychotic symptoms later in life are more common than previously thought. What is psychosis? So psychosis is a severe mental condition in which thought and emotions are so affected that contact is lost with external reality. What is a delusion? A delusion is a belief that is clearly false and that indicates an abnormality in the affected person's content of thought. Hallucinations. It's where you see, hear, smell, taste, or feel things that appear to be real, but only exist in your mind. Some psychotic symptoms. So as we already kind of defined, some psychotic symptoms will be hallucinations, delusions, as well as disordered forms of thinking, not being able to care for yourself, as well as having disorganized speech. Sometimes you'll hear mentioned positive symptoms and negative symptoms of psychosis. So the positive symptoms are any behaviors or thoughts such as the hallucinations and delusions. The negative symptoms are where people appear to be withdrawn from the world around them and they take no interest in everyday social interactions and often appear emotionless and flat. So what is the DSM-5 criteria for schizophrenia? So the DSM-5 criteria for schizophrenia, you need 2 of the 5 below. So the 5 that I'm speaking about will be delusions, hallucinations, disorganized speech, disorganized behavior, or catatonic behavior, and or negative symptoms. You need 2 of those, but as well as needing 2 of those, one of the 2 needs to be either delusions, hallucinations, or disorganized speech. So you need to have those symptoms for a portion of at least 1 month. Following that, you should have a significant portion of time where the onset of disturbance is greatly impacting the level of function in one or more areas, such as work, interpersonal relations, or self-care, and is markedly below the level of achieved prior to the onset. You also have to have a continuation of signs and disturbances that persist for at least 6 months. So you have to have these symptoms and level of functioning impairment for at least 6 months to be able to qualify or meet the criteria for schizophrenia according to the DSM-5. As well as that, you also have to make sure you rule out schizoaffective disorder or bipolar or depressive disorders with psychotic features. Because of the running theme, as we kind of already discussed, we have to make sure the symptoms aren't due to another mental disorder or due to physiological effects of substances or medications or due to another medical condition. Prevalence in the elderly. So prevalence for schizophrenia among the elderly range from 0.5 to 1. Cognition in older schizophrenia patients. So what we've learned is that cognition seems to remain pretty stable, other than the changes expected from normal aging. So the changes that you should expect would just be like sustained attention, word finding, and being able to hold information for long periods of time, word finding and sustained attention. Depression in older schizophrenia patients, also you have that comorbidity of depression and schizophrenia. It tends to be a major predictor of suicidality in older patients with schizophrenia. When talking about poor functional capacity, it will be associated with poor neuropsychological testing, and neuropsychological testing tends to measure how well a person's brain is working. So what is being tested when you're having neuropsychological testing done is reading, language usage, attention, learning, processing speed, reasoning, remembering, problem solving, mood, personality, and more. Other things that are associated with poor functional capacity would be lower educational level, as well as the negative symptoms that we were talking about, such as being very withdrawn from your external environment. Late onset schizophrenia, about 23% of patients with schizophrenia had an onset of this disorder after the age of 40. And about 3% of these patients were reportedly older than 60. So when you're diagnosed with schizophrenia after the age of 40, it is called late onset schizophrenia. So widely, schizophrenia, the causes are unknown, but we are aware of some risk factors. So some of the risk factors mentioned would be family history as well as genetic risk. And in the older population, we tend to see women predominate, and this is due to the thought of estrogen being a protective factor. So when women go through menopause, they lose that protective factor, and that is why women predominate in patients with onset in middle to late life schizophrenia. So there's also a term called very late onset schizophrenia. And very late onset of schizophrenia is when you're diagnosed with schizophrenia after the age of 60. So the differences of presentation in regards of when you have the onset of schizophrenia. So we've talked about late schizophrenia, very late schizophrenia, and the differences of presentation. We've noticed there tends to be better cognition, less negative symptoms, and you also require lower antipsychotic doses. So those are some of the beneficial things you can say about having a later onset for schizophrenia. But also with later onset schizophrenia, you do have a greater risk of target dyskinesia, which we will talk more about a little bit later on in the presentation.
In a small minority of people who have schizophrenia, it starts not at the usual age of between 25 and 35, but instead around the 40s. And there's also a very late onset schizophrenia that tends to start around the 60s. This is more frequently occurring in women, and around the postmenopausal period, so after they've had their menopause. So there's some theories that involve the effects of estrogen withdrawal on leading to the onset of schizophrenia at that time. People who develop late onset schizophrenia more often have hearing or visual deficits, which we think maybe leads to a higher likelihood of paranoia, and that's why it sort of comes on at that time. They also may have had, before becoming ill, a tendency to have some paranoid ideas about people, or to be more withdrawn than the average person. And so those are some of the risk factors for late onset schizophrenia. People who have late onset schizophrenia tend to, compared with people who have earlier onset schizophrenia, tend to be a little bit more paranoid. It's primarily that they develop paranoid delusions about other people, wanting to hurt them or plotting against them. The good news about late onset schizophrenia is that usually it responds to lower doses of medications, and so is more readily treated with support and medications.
So I thought that was a pretty good video to insert right there, because it kind of summarizes some of the things that we've already talked about the late onset versus very late onset, and some of the beneficial things like requiring lower doses of antipsychotics. And we talked about how your cognition should be a little bit better. So once again, before making the diagnosis, you want to always make sure you rule out other conditions, medical conditions such as delirium or dementia, because if you present with delirium, you can also present with psychosis, as well as if you have a primary diagnosis of dementia, you can also have some psychosis as well. So you want to make sure that you rule out medical conditions, medications that can also cause psychosis. We talked about steroids in the past, where they can cause some psychosis. Abnormal labs. So the abnormal labs, you want to make sure you do a complete workup, because that will be ruling out your delirium, making sure the person doesn't have any infections, any electrolyte abnormalities or anything like that. And once again, making sure the psychosis isn't due to substance intoxication or withdrawal. So as I talked about, you can present with psychosis and dementia. So psychosis and Alzheimer's disease, there's about a 40 prevalence of psychosis in Alzheimer's disease is estimated to be about 41%. And then if psychosis is present in Alzheimer's disease, then the diagnosis is associated with a more rapid cognitive decline, greater impairments in executive functioning, and a greater prevalence of extrapyramidal symptoms, which we call EPS, compared to patients with Alzheimer's disease that don't present with psychosis. Here is a video just explaining a little bit more about EPS, extrapyramidal symptoms.
Hi, I'm Katie Arison here with another Hippo short. We all know that antipsychotics can cause extrapyramidal symptoms, but at times I forget what actually is underneath that umbrella. So let's talk about it. The first is acute dystonia. That's a painful or prolonged muscle contraction, like trismus or torticollis. It can happen hours after the patient takes the medication. We treat it with diphenhydramine or an anticholinergic like benzotropine. The next is dyskinesia, which is pseudo-Parkinsonism, which is like shuffling gait or cogwheel rigidity. This can occur days after taking a medication. We treat this with a dopamine agonist like amantadine or an anticholinergic. The next is akathisia, which is restlessness that looks like distress. The patient is actually not in distress, but just appears so with how restless they are. This can start weeks after taking the medication. We treat this by trying to lower the dose to see if that helps, or adding a beta blocker like propranolol. The one they're probably most familiar with, and the one that's scariest really, is tardive dyskinesia, because it could be irreversible. This is those repetitive, involuntary, painless oral facial movements like teeth grinding or lip smacking. This can occur months after taking the medication. So we can treat this by discontinuing that particular med or lowering the dose. But remember, adding an anticholinergic initially may worsen the symptoms. And then the granddaddy of them all, the one that can cause death, is neuroleptic malignant syndrome. This causes altered mental status and muscle rigidity and autonomic instability because of dopamine inhibition. It can happen anytime on these medications, but usually in the first 3 months. And the treatment for this is immediately stopping the med. These patients need the ICU care and they need a dopamine agonist. So next time you write for a medication like this, remember the side effects from it, and you can hopefully remember all the things that kind of fall under the umbrella of extrapyramidal symptoms.
Okay. Patients with new suspiciousness and paranoia. So you want to make sure you do a careful psychiatric evaluation, as well as getting collateral information from maybe a family member to kind of see when did these symptoms start, to make sure you're once again ruling out if it's possibly due to like a medical condition, a medication change, or just like a recent change that the patient has gone through, as well as older adults at times are abused / neglected. So investigation could also be warranted when we're talking about new suspiciousness or paranoia. And then I can't reiterate enough to make sure you always do a laboratory workup when you have like a new presentation, especially in the elderly population that we're talking about today. So now we're moving on to delusional disorder. So the delusional disorder is the prevalence of having one or more delusions for a month or longer, and they have never met the criterion A for schizophrenia. So once again, you can, when you're making diagnosis according to the DSM-5, you have to always make sure you're ruling out other mental illnesses as well as medical conditions, making sure it's not due to a substance or medication. Apart from the impact of delusions or its ramifications, functioning is not markedly impaired when we're talking about delusional disorder, and behavior is not obviously bizarre or odd. If manic or major depressive episodes have occurred, these have been brief relative to the duration of the delusional period. And once again, the disturbance is not due to a substance, another medical condition, or better explained by another mental disorder, such as a body dysmorphic disorder or OCD. So there are several types of delusions that you can have, such as erotomanic type. So that's when another person is in love with when your delusion is that another person is in love with you, the individual. Grandiose, that's when you think you have the conviction of having some great but unrecognized talent or insight, or having some important discovery. As well as jealous type, thinking that your spouse or lover has been unfaithful. You have persecutory type, when you believe that you are being conspired against, cheated, spied on, followed, poisoned, or drugged. You have the somatic type, so that's when your delusion involves bodily functions or sensation. And you have mixed type, when they don't necessarily fit into one category that has been previously mentioned. And then you have an unspecified type, when the dominant delusional belief cannot be clearly defined or is not described in specific types. So when you're talking about a delusional disorder, lifetime prevalence is about 0.2%, slightly higher among women than men. In men, typically it appears around 40 to 49, and in women around 60 to 69. And the risk factors for delusional disorder will be a family history of schizophrenia or certain personality disorders, including avoidant, paranoid, and or schizoid. So now when you're talking about treatment for different types of psychotic disorders, you want to talk about the antipsychotic agents. So we have the typical antipsychotics as well as the atypical. So you have like thorazine, prolixin, Haldol, which are the typical antipsychotics, as well as the atypical antipsychotics, where it's like Abilify, Clozaril, Zyprexa, Invega, Seroquel, Risperdal, or Geodon. And so when you're talking about treating with antipsychotics, so the atypical antipsychotics have been linked to an increased risk of metabolic syndrome. And when we say metabolic syndrome, that is including such things as like diabetes, dyslipidemia, and obesity. And so one of the main things about having these presentations is providing the information. So if you know if someone is on one of these medications, you want to make sure that when they're going to their primary care physicians, they're frequently getting their hemoglobin A1C. That's how you diagnose diabetes, getting your lipid profile for dyslipidemia, making sure they're tracking the weights to make sure the patient isn't gaining too much weight while on the medication, as well as leading to a worsened cardiovascular risk profile. So you want to make sure you're getting those EKGs yearly while you're on an antipsychotic. Other patients have a high risk of adverse antipsychotic effects. Older patients have a higher risk of adverse antipsychotic effects as a result due to the coexisting medical illnesses as well as medications. And so when treating antipsychotics in dementia, because we kind of talked about how you can present with psychosis in dementia, there is kind of a black box warning with using antipsychotics in dementia. So prescribing antipsychotics to patients with dementia can increase the cerebral vascular disease, i.e. strokes, and mortality in the elderly. So when you're prescribing these type of medications with to a patient that has dementia, you have to make sure you're considering risk versus benefits in these cases.
Let's take a moment to explore a little-known condition that affects hundreds of thousands of Americans. Tardive dyskinesia, or TD, can develop in people who've needed antipsychotics or other prescription medications to manage a serious mental illness, bipolar disorder, for example, or schizophrenia. TD is a neurological condition that causes repetitive involuntary movements. People may smack or pucker their lips, blink excessively, grimace, or twitch. TD can make it difficult to sleep, work, or exercise, and it can be a blow to patients' self-esteem. These symptoms can also attract stares and unwanted attention. For people with TD who already struggle with mental illness, the added stigma is hard to bear. Some people withdraw from family and friends. Others abandon their antipsychotic medication without consulting their healthcare provider. People living with TD need to understand their symptoms. They need to be empowered to seek treatment, and they need the support and understanding of their family, friends, and communities. Learn more about TD at movementdisorderspolicy.org and help raise awareness and reduce stigma using the hashtag TDAwareness online.
And that was kind of beneficial because we've talked about some of the benefits of having the later onset schizophrenia, so the very late or the late onset schizophrenia. So you have better cognition, less negative symptoms. However, you do have a greater risk of having TD. So that's why I wanted to make sure we discussed what TD actually was. drugs for schizophrenia, you can also use psychosocial treatments. So some of the psychosocial treatments mentioned would be cognitive behavioral social skills training. And so what that is it combines cognitive and behavioral coping skills, training in social functioning and problem solving, resulting in greater cognitive insight and performance of everyday living skills, as well as the FAST, which is the functional adaptation skills training. And so this was designed to improve medication management, social skills, communication skills, organization/planning, transportation, and financial management. So with the FAST, it resulted in improvements in daily living skills and social skills, but not in medication management. So there are other options outside of medications as well. Thanks for listening. Let's see.
Okay, let me get the mic to Ken.
Okay. Any questions in the audience? Crystal clear. Okay. Do we have any online? We don't see any evidence of any questions.
Yes, I have one, Ken.
Yes. Who is that?
This is Shirley.
Oh, Shirley, what a surprise. Go ahead, Shirley.
I'm wondering if this is acute onset always, or whether there's a buildup and people can recognize that there are changes occurring. Is this a sudden onset of a psychosis? Or how do you describe that?
So there is a schizophrenia that occurs like before the age of 40. So then you do have like a longer term of symptoms, but you can have some changes that occur over time. So when you were saying things like not being able to care for yourself, not feeling connected to your external environment, so having those negative symptoms. So it doesn't necessarily have to present 100% initially with the psychosis, the hallucinations, but you can see subtle changes in how you're like connecting to the external environment, if that kind of answers what you were asking.
Yeah, thank you.
Mm-hmm.
Very interesting and frightening.
Thank you. Thank you, Shirley. Any other questions? All right. Well, I guess all of us are experts now on geriatric schizophrenia associated syndromes. So thank you very much, Dr. Lewis. We appreciate your efforts.
Thank you so much for having me once again.
Okay. And let's see, next week.
We have delirium and dementia.
Yes, delirium and dementia. So, sort of
Check
like
the schedule.
leaders can win a football game. That's only when you're delirious do you have that attitude. Anyway, that'll be an interesting topic for us. Who's going to give that talk, Dr. Lewis?
Yes, Dr. Stephanie Gerialdi.
Yeah, okay. Very good. Dr. Gerialdi was our first speaker, so we will welcome her back at that time. Thanks again.
All right,
Bye-bye.
thank you so much.